Welcome to Neuroconections, a vodcast series developed by the World Stroke Organization and Ipsen. The series aims to shine a light on the experiences of people post-stroke and discuss what's involved in providing consistent, high-quality care to meet their needs. Hi, I'm Dr. Michelle Nelson, and in this three-part series, we'll hear from stroke experts from around the world as we discuss post-stroke care and the rehabilitation landscape. We'll look at solutions to improve patient care, support recovery, and reduce healthcare costs. Stay tuned for some fascinating insights. Welcome to Episode 1 of Neuroconections. I'm your host, Dr. Michelle Nelson. And in this first of our three-part series, we're going to discuss the state of post-stroke care globally and the implications for patients, family members, healthcare providers, systems, and economies. With 1 in 4 of us expected to have a stroke in our lifetime, and over 100 million people around the world living with the impact of stroke, the burden of stroke is high and set to increase. As more people thankfully survive, it's crucial that we act now to address the global burden of stroke. We need to ensure that all people have access to timely care and rehabilitation while minimizing the socioeconomic burden of inaccessible or delayed treatment. We're joined today by Dr. Monica Verduzco Gutierrez, a physiatrist in the Department of Rehab Medicine at the Long School of Medicine at UT Health San Antonio, and also Professor Dorcas Gandhi, a neurophysiotherapist at the Christian Medical College and Hospital in Ludhiana, India. Thank you both for joining us today. I'm looking forward to our conversation.
Thank you for having us.
Thank you really for having us.
Okay, it's my pleasure to be here with you both, Dr. Gutierrez and Professor Gandhi. I'm wondering if we can start the conversation with giving the audience an opportunity to get to know you. So I'm wondering, Monica, can you start by telling us a little bit about your background and how you came to stroke care?
I'm a pulmonar physician. I take care of patients who need neurologic rehabilitation, especially after stroke. I always say I didn't know about this field before I came into medical school, but I did know that, growing up, I'm the first person in my family to be a physician, and my grandfather, who is the patriarch of the family, a veteran from World War II, he had a stroke, and this was something that was very shocking and devastating to the family to see, our hero be impaired so much. And he had a stroke and ended up the rest of his life being in a nursing home. And so this is something that really drove me.
Yeah, thank you for sharing that. It's amazing how many people, when we talk to them and they work in stroke care, recovery, rehab, they often have a precipitating event or experience. And like you, my grandfather had a stroke and did not have optimal outcomes. And so my family was unsurprised that I ended up working in stroke rehab and recovery as well. So yeah, thank you for that. Dorcas, I know you also had a precipitating event. So I don't know can we start with a little bit about you, your background, and how you came to stroke care?
So my work includes not just stroke patients, but neurorehabilitation in general. We see spinal cord injuries, Parkinson's, etc. And like Michelle was mentioning, before this job, 2 jobs ago, I would say, there was this non-governmental organization that I was working with, which had sort of adopted 15 villages in the semi-urban and rural settings of southern India. And here, the main aim was to serve those with HIV and leprosy, pediatric neurological conditions. However, I did see that there were so many with stroke who did not know what to do or whom to talk to. And that's what triggered my interest with stroke rehabilitation. And 10 years later, I am here trying to do my best for the field.
So then that sets up the perfect starting question. We talk a lot about quality post-stroke care, but I'm wondering from your perspective, what does that mean? What does it mean for people and their families? What does it mean for clinicians? What does it mean for systems? So you're coming from the US and India. I'm in Canada. What does good quality stroke care look like?
So I think, you have to think of it in different perspectives. So like you said, first and foremost, the patient and their family. So that has to be the center of good quality post-stroke care. And so when I think about the patient, their family, what is comprehensive, what is patient-centered, goal-oriented care? So we have to understand where they're coming from. We have to be trauma-informed. We have to think about their full spectrum of needs. So both the medical, the psychosocial, the vocational, the emotional, the support, the physical, and really come to it from their perspective. And then, as a clinician and a physician and thinking about working with stroke teams, then what is good quality stroke care and post-stroke care? Of course, we know stroke care, there's, here in the US, it's like get with the guidelines and get people, early access to treatment. And then post-stroke care, there is a lot of guidelines on post-stroke care. Sometimes they're not as, followed regimen to the T, but I think it's interdisciplinary collaboration across multiple specialties. So as a patient, first seen by a neurologist and then gets into the hands of a physical medicine and rehabilitation physician with all the rehabilitation specialists working to meet their needs. And then do they have appropriate follow-up with other specialties in cardiology and, behavioral health services and anything else that they may need? And are we still following evidence-based practices? And then for healthcare systems, we have to look at it. Are there integrated care pathways? Are patients making it through these continuum of care from acute to follow-up? And then we have to think of it as stroke and post-stroke is a chronic disease. These patients have to be followed for their lifetime because they are going to have lifetime needs.
Dorcas, I saw you nodding during a lot of that. So thinking about the Indian perspective and context, what does it mean for you and patients' families in your systems?
I so resonate with what Monica mentioned. The context, the sociocultural background that they come from would influence the kind of recovery, their journey, functional journey, and their role in society would all influence the whole journey that they're having after a stroke. And that's why it needs to be contextual, in addition to being accessible and affordable, that even the high-income countries aim for any rehabilitation to be. And with respect to clinicians, it's vital that these treatments, they are grounded in latest research while remaining practical to implement in everyday practice with respect to, the resources and the time that rehabilitation takes. It should be practical for clinicians in low resource settings because the therapist to patient ratio in low resource settings is haywire. And for the broader healthcare system, just like Monica mentioned, solutions must not just simply be cost effective, but also scalable. With robust mechanisms for ongoing monitoring, which is very essential in low resource settings. Without monitoring, without periodic follow-up, we don't see adherence to be as good as it needs to be. So it's complex, but then that's what good quality care is, which is realistic, evidence-based, accessible, affordable, and contextual to the patients. Yeah.
I know you recently published a paper looking at global access to rehab. Can you comment on global access?
We saw that the models of care that work in low and middle income countries, although even high income countries use it, like caregiver-led training, tele-rehabilitation, periodic monitoring by workforce that are trained in stroke rehabilitation is all essential. Yes, definitely. But if it is not scalable at a national level, if it's not scalable even at a small regional level, it is not going to make much of a difference with respect to direct and indirect costs. That's just one of the examples. Within India, we see the Ministry of Health and Family Welfare, which are pushing clinicians towards referrals to rehabilitation, which is not a normal behavior among clinicians in India. So they are pushing, and there's a white paper policy draft that has come up, which is encouraging clinicians to do this, not just for stroke, but NCDs in general. So there is so much happening. There is hope beyond the barriers that we see.
You're touching on, in earlier conversations, we've talked about, that stroke is not an equal opportunity condition, that there are inequities in who has a stroke, where they live when they have a stroke. So Monica, I know you've also worked in this space, so maybe we can spend a little time talking about inequity in stroke incidence, but also inequities around stroke access to care. Monica, I know you have thoughts.
I have thoughts, yes. So definitely there's inequities in who gets stroke, who has access to stroke care. Stroke has a very, very large global burden. I will kind of give a perspective first from the U.S. So we have an area in the U.S. that's called the stroke belt. And in the stroke belt, which is a lot of the Southeast United States, that's where we see that people have more stroke, have more deaths from stroke, more disability related to their stroke, higher rates of stroke, poorer outcomes in the end. And so these are sometimes also countries that have more populations of persons who are from minority backgrounds and groups, and also ones who may not have the same level of access to health insurance and lower income populations. And so this is something that is unfortunate that has to be addressed. And so we know that if patients can't get early and quick access to care, they're going to have, worse stroke outcomes. And we see this also, anywhere across the U.S., it's seen for people who maybe live rurally, for people who don't live close to a stroke center, for people who don't have the proper kind of insurance or underinsured, then even their outcomes may not be as great because they don't get access to post-stroke rehabilitation services. And I see that is what creates some of the differences that I think that we see in post-stroke care. Of course, we know that global burden, high-income countries versus low-income countries is going to be a difference also in global outcomes to stroke care. And I really think, unfortunately, location does matter. I had a patient once who had a stroke on an airplane. They had to emergently land the airplane. It was an international flight in Germany, and he got the most amazing post-stroke rehab care in Germany. Like months and months of inpatient intensive rehabilitation with the use of all their devices and everything. By the time he got to the U.S., we're like, oh, wow, you had so much more rehab than anyone would have gotten here. And I guess that's the lucky part of having a stroke. If you're going to have one on an airplane, depends on, where you land. But it shouldn't be that way. I hope that, internationally we'd have good access, good care, good rehabilitation services, and it just isn't the case.
Yeah, thank you. Dorcas, in a previous conversation, you had shared experiences of people being discharged across the vast landscape of India, and that there were very different experiences. And I'm wondering if you can tell the audience that story to really highlight that even within a country, there can be vast differences in access and experience.
Yeah, thank you, Michelle, for bringing that up. So healthcare access and resources, and it's variable when compared to an urban and a rural setting in India. But I think that's the case in high-income countries as well. But the causes for these differences to patients' behavior to seeking rehabilitation services may be different in low-income countries. One such example was what Michelle was referring to. Back when I was in the NGO I was working, the social stigma around stroke was so intense in that particular region. Again, I'm not generalizing here. In that particular region, it was quite intense that the patient did not even step out of his house. He had issues with speaking. He had issues with using the washroom or even realizing that he had to use the washroom, apart from the normal physical, motor, and sensory issues that all of us would know of.
Yeah, I think what you're making me think of, Dorcas, is certainly within the Canadian context, we have huge variability based on where people live, their access to multicultural factors, race. And I think, Monica, you had flagged this as well, that even within a country, not everybody has equitable access. So for our audience, let's make it really clear. What are the ramifications if people don't get access to or they have insufficient recovery supports? What does that mean for them, their families, and our society?
Yeah. First, to your point about access. In Canada, I have a physician friend. He sometimes has to take a helicopter to get to places to be able to treat patients for their post-stroke spasticity. So it is, there is very huge need for physicians that deal with that kind of complications from stroke. And so, like you said, the implications are quite significant because you think that, like I said, stroke is a chronic disease after you have it. And that means it can affect someone in so many different ways. Physical, so they can be paralyzed, they can have decreased sensation, they can have development of spasticity, which is kind of the increased tone and tight muscles that are pulling all the time and make movement difficult and and can cause pain and hygiene issues. They can have issues with their speech. They can have issues with bowel, bladder, mental health issues, risks for having other strokes in the future. And it really can make a difference. Like even in the United States, where we're supposed to be a high-income country, we spend so much on our healthcare in the United States, yet still you can see disparities. And even, like I talked about my grandfather, he had Medicare benefits. He had veterans benefits, and still he didn't get access to inpatient rehab. Do you get a follow-up with a neurologist? Do you get a follow-up with a physical medicine and rehabilitation specialist, someone who understands what spasticity is and can treat your spasticity and who will look at you holistically? And it makes a difference on ultimate outcomes. If you're introduced to an interdisciplinary team, physiotherapists, speech therapists, it's important for, in the end, what stroke recovery looks like for that person.
Dorcas, anything you want to add?
Well, yeah, just to keep it short, but there are these obvious consequences that all of us know of: the financial strain and the growing number of people living with the disabilities who are neither functionally nor socially productive if we don't cater to their needs in an effective way.
As you were saying that, it reminded me that the Stroke Foundation of Australia just released an economic burden of stroke report. And the profound economic impact of stroke in Australia, and we know worldwide, is it's actually increasing. So if we don't start thinking about interventions to reduce the global burden, we're going to have more and more and more people living with the impact of stroke, not being able to contribute to their family's life, their employment. And so it's such an important topic. Let's talk about some positives. Let's talk about things we know are working. So for people who might be listening and saying, okay, so what can we do? What's working? Let's highlight a couple of examples of things that we know are working, and to your point, Dorcas, could potentially be scalable. So Dorcas, you've identified a couple of things, but I'm going to give you the first kick at the can, something that you've seen that's working.
One such example is a set of contextualized exercise that a PhD student here in Southern India is working on, of bimanual tasks-based upper limb rehabilitation, which has shown incredible improvement in the functional outcome in subacute as well as chronic cases. And this can be done at home while the physical therapist can monitor remotely of the sessions that are happening at home. Then there are adapted sports-based regimens that community dwelling stroke survivors can follow. For example, volleyball being played while sitting on their wheelchair or on the chair just outside their houses. And similar procedures of contextualizing, rehabilitation protocols to make it relevant, functionally relevant to the country patients is done in Philippines. We here are doing it in India right now with assistance from Singapore. Singapore is doing it. Rwanda is doing it. So a lot of positive thought is going into making the clinical protocols meaningful to patients, making them feel relatable to what is exactly happening. So keeping the patient at the center while making it contextual and low cost is what many countries are looking at and are having small scale success as well.
Yeah, I really love the idea of making sure that we're contextually dependent or driven, so that we're taking the context of our population into account, but thinking about what might support transferability of those interventions to other contexts. And that's a tricky evaluation and knowledge mobilization challenge. So, Monica, I'd be interested in your thoughts.
I think one thing that we haven't touched on is telerehabilitation. And so really when we think about how some places have lack of access to care, infrastructure isn't great, and a big burden on the person who has had stroke to the family, then there's options for telerehabilitation. And both in ways like we talk about the whole stroke continuum from, getting access to telestroke care and making sure that they can get treatments right away, clot-busting drugs, those types of things, to then afterwards following up with physicians. They may have follow-ups via telemedicine, and then even doing rehabilitation. There's been some work in Australia and the U.S. on doing telerehabilitation with specialized therapists who can treat a patient remotely. So that's one example. Another thing is there's some initiatives around using community health workers. How can we get community health workers into to address more social determinants of health or non-medical determinants of health to help address these needs for patients. And this also helps with trust and relationship building. And again, if there's any possibility of getting multidisciplinary stroke teams in low-income urban settings, so even in big major cities that may have major hospitals, in those low-income part of the cities, sometimes doesn't have the same access to stroke care, post-stroke care. And so we continue to need multidisciplinary teams in those settings as well to promote access. So we have to really think about holistically treating the patient for their post-stroke needs.
So I know you both have published and have touched on telerehab, and so it does seem like an area that has been, particularly in recent years, it has been widely adopted and successfully used. How is that going to address equity issues and access and equity? Let's wrap that up for people and make it really explicit.
I think, like, you're right. I didn't use 1 minute of telerehab before the pandemic, and then now that the pandemic has happened, we quickly had to adopt it. And I'm not going to let it go for my patients. I can do sessions, coaching, counseling, assessments, as long as they have, technology, which now a lot of people even have the phones that have cameras. And so they're able to use that. I'm able to see sometimes patients in their physical therapy sessions and get to even discuss with their physiotherapists right when they're in the sessions as well during these visits. So utilizing these platforms to even help me synchronously work with a multidisciplinary team, that's very good for patients. And then also they can now get these services, and more research is still being looked at and done, at least here in the US, of using these technologies to actually do the physical therapy, the occupational therapy, the speech therapy, especially people who it may be more burdensome to come into a center. So I think it is going to be here to stay, and we have to consider this for our patient population, especially helping address equity and access to care.
Yeah, thanks. And Dorcas, I know you have thoughts on this because it was called out explicitly in your Access to Rehab paper in Stroke a couple months ago. So I'd be interested in your thoughts.
Yeah, just to reiterate that it's like Monica mentioned, it's not in its perfect form right now, telerehabilitation for stroke rehab. But in low resource settings, something better than nothing is what we rely on. So why not use telerehabilitation when it gives you the opportunity to make the patients active wherever they are? The only drawback that we find is in severe strokes or strokes that have issues with balance and gait therapies are tricky or in some cases even unsafe to be done using telerehabilitation. But we do have wonderful virtual telerehabilitation, what are they called? Toolkits, resource kits that I think University of British Columbia, University of Melbourne have brought out that are useful even in low resource settings. So some guidelines, even for the providers to become more confident, work around this needs to be done. We need more funding from governments and funding bodies to work on such projects.
Yeah, thanks for raising that. One of the things that we're exploring in some of our own research is unintended consequences of access to virtual care. And so certainly all of the populations that we've been working with highly value tele-based or virtual care modalities. And, they're seeing benefit. So I love your comment about ensuring people have access to something is better than sending them home with access to nothing. One of my questions that I keep exploring is, what's the trade-off? What are the potential challenges of virtual? What are we missing? Are they actually not getting the social connection through their programs? And so we're building that in now to some of our other research studies. I have one last question for you. After all of the conversation we've had, what is one key takeaway or key message you'd like to make sure you deliver to our audience, which could be comprised of people with lived experience, clinicians, policymakers, something that is a strong takeaway or final thought that we could end the podcast with?
We talk about equity and global post-stroke care. And again, I'm going to talk about the importance of centering the patient, the person, I'm going to call it the person that's had stroke, and that when we develop programs, we have to really consider the deep, respect and understanding of their cultural practices and health beliefs. One of my mentors always taught as, if a clinician's listening to this, then I always think of would good enough be good enough for you? If this was yourself, if this was your family member, Are we doing enough for that patient and for their needs and for their, understanding their background and their beliefs and everything else?
Yeah. Thank you. Dorcas.
That got me thinking as well, Monica. Thank you for bringing that out. But what I was thinking of was how this whole journey that all of us are taking to make stroke rehabilitation impactful and better and of high quality involves multiple stakeholders. So we cannot be putting the ball in another's court. It has to be every stakeholder doing their responsibility well, be it policymakers, be it the clinicians, be it the therapists, be it the persons with the lived experience of stroke or their caregivers. There are multiple stakeholders here. And I think that should be everyone should do their responsibility to the best possible limit. And that's when we will see a beautiful dish forming. We have this saying in India where we use a lot of spices in our cooking. You know that, isn't it? So when all the spices do their job well, only then the dish turns out to be beautiful. And that's what is needed.
I love that analogy, Dorcas. Thank you. I think my takeaway in this conversation, dovetailing on the two of your comments, we often think about pathways of care as discrete experiences, different sets of clinicians, different sets of team members, different set of interventions. And I think to your point, and I'm just going to echo, we're actually talking about an individual, a person who experiences the entire process from acute to community. And so thinking about that and the need for really good, seamless supports and services as a way to promote access, ensure optimal outcomes, I think is so important. And then we need to overlay the consideration of ensuring that everybody has access to high quality rehab and care. So I just want to thank you so much for your time today. This has been such an enjoyable conversation, and we probably could go on for another 30 minutes, but I just want to say thank you so much for taking the time to share your expertise and insights. I just want to say a big thank you to Monica and Dorcas for joining us today and sharing their insights on the barriers to post-stroke care. I found it to be such an interesting conversation, and I hope you found it insightful as well. Now that we've spent some time talking about the challenges or barriers in post-stroke care, in episode 2, we're going to turn to solutions. We're going to talk about what good or even great care can look like and what the implications are for people and their families in the long term following stroke. And to make sure that you don't miss that conversation, make sure you're subscribed to Neuroconections. We look forward to seeing you there.